Okay, thank you. Good evening, everyone. Thank you, Marla and Russell. As Marla said, I am tasked to discuss with you membranous nephropathy and FSGS. I have nothing to disclose. And I want to start with the M-type phospholipase A2 receptor antibody, now the game changer of membranous nephropathy. And the discovery of the PLA2 receptor in 2009 as the primary target of the PLA2 receptor antibody identified in 70 to 80% of patients with MN has made it a renal-limited autoimmune disease. And as seen in this slide, there are two potential pathways proposed leading to the clonal expansion of B cells into plasma cells secreting antibodies and the generation of your memory B cells. So first, you have your PLA2 receptor antigen that can bind to your autoreactive B cell, which is internalized and fragmented via the MHC2 complex and presented to the T helper cells, which are stimulated to release cytokines that would stimulate clonal expression and the sequence and the sequence of events. The other pathway, the second pathway, involves the PLA2R receptor antigen recognized by the antigen-presenting cell, and in the presence of your co-stimulators will also stimulate your T helper cells to produce those cytokines that would again stimulate or activate the sequence of events. And at the same time, there's also the activation of your T regulatory cells, which we know promote tolerance by inhibiting the activation of your T helper cells. So we will see later that this is the basis for the action of rituximab in MN, that of inducing B cell depletion and increasing the levels of your Tregs. The 2020 KDIGO-GM guideline says that kidney biopsy may not be required to confirm the diagnosis of MN in patients with a compatible clinical and serological presentation. Your PLA2 receptor antibody is a biomarker that can establish the diagnosis with high accuracy, with a sensitivity of 78% and a specificity of 99%. Kidney biopsy should be done for purposes other than establishing a diagnosis of MN in patients who have these positive antibodies. And that is because this does not preclude the presence of other concurrent diseases that can overlap in this proposed categorization. Thus, this does not obviate the need for workup for infection and age-appropriate cancer screening. Emerging data suggests a possible association between your thrombospondin type 1 domain containing 7A antibodies and cancer. So, how do we utilize your PLA2 receptor antibodies in our decision to do a renal biopsy? So if you have a patient with nephrotic syndrome with positive PLA2R antibody, then you have to assess the patient for the risk. Risk assessment to low risk, if the patient has normal EGFR, non-nephrotic proteinuria, or albuminuria of more than 3 grams per deciliter. So if the patient is low risk, no need to do the kidney biopsy and just give supportive care. However, after giving your supportive care, you still consider immunosuppressive therapy, or there is rapid unexplained deterioration of your EGFR or unusual clinical course, then a biopsy is needed. So you can put that patient into high risk together with these criteria. So in decreasing GFR, declining GFR, increasing proteinuria, and increasing antibody levels. So if you're high risk, you do a kidney biopsy and initiate therapy. On the other hand, if you're negative for the PLA2R antibody, you need to do a kidney biopsy and in the same way, do your risk assessment. So we go to our case. This is a 31-year-old female who was diagnosed with psoriatic arthritis in 2016 with these following medications. And she had, in 2019, she had a 1-month history of nephrotic syndrome. She was normotensive and with normal GFR. She was slightly anemic, but normal FBS, negative for lupus, negative for hepatitis, negative sexual history. This is her biopsy. As you can see, this is the PAS stain, which shows you thickened GBM. Just believe me that this is thickened GBM. And in immunofluorescence studies, she had dominant IgG staining in the basement membrane and the mesangium. On EM, you will see here long stretches of subepithelial immune deposits in the GBM. And if you can see this, these are spikes in the GBM, and notably, diffuse foot process effacement. So first question, how will you treat this patient in 2020? This is your answer. From the survey, the fellows answered ACE-ARB plus rituximab, the same as with the consultants, but some of the fellows here are, I think, more aggressive. They will give cyclophosphamide. So the decision to initiate treatment should be based on our knowledge of the natural history of membranous nephropathy, as shown in this Italian study, where 100 biopsy-proven MN patients were not given any immunosuppressive therapy, only supportive therapy for 6 months. And as you can see, 65% of the patients had partial remission and complete remission, 35% had sustained proteinuria, and 16% went to ESRD in a span of 5 years. Having said that, because spontaneous remission is relatively common in MN, it is important to assess the risk of progressive loss of kidney function prior to deciding about whether and when to implement immunosuppressive therapy. And based on that study, prolonged follow-up may be needed before one can conclude that the patient with MN will not have a spontaneous remission. And because of that, as in 2012, the KDIGO guidelines says that all patients with primary MN and proteinuria should receive optimal supportive therapy for about 3 to 6 months. And immunosuppressive therapy is not required if the proteinuria is non-nephrotic and your eGFR is more than 60. So for patients with MN with at least one risk factor for disease progression or serious complications of nephrotic syndrome like AKI or thromboembolic events, it is recommended to use either rituximab or cyclophosphamide and steroids or tacrolimus-based therapy for at least 6 months. So this is the risk-based treatment for membranous nephropathy. So for low risk, wait and see. Our patient falls under moderate risk because she has normal eGFR, but she has more than 4 grams of proteinuria. But we did not have antibody levels for this patient. So it's wait and see, and then you can give rituximab or calcineurin inhibitor. If you have a high risk or very high risk patients, then cyclophosphamide is the recommended drug because it is only with cyclophosphamide that long-term renal outcomes have been proven. This is the dose schedule of the immunosuppressives, as you can see in the KDIGO guidelines. So several randomized trials have demonstrated the benefit of immunosuppressive therapy compared with supportive therapy alone in patients with primary MN, classified as having moderate risk for progression. So I just selected 3 studies. And this is the GEM-RETUX trial. This is a French trial involving 75 patients with persistent nephrotic range proteinuria after 6 months of treatment with non-immunosuppressive therapy, so supportive therapy only. And they randomized the patients, one group to the rituximab plus supportive therapy, and another group to no rituximab. And at 6 months follow-up, there was no significant difference in the primary composite endpoint of complete remission, meaning less than 500 milligrams per day of proteinuria, or partial remission, less than 3.5 grams per day with more than 50% reduction compared with baseline between the 2 groups. However, they also noted that there was higher serum albumin levels in the rituximab group, and the anti-TAT2R antibodies, which were present in 73% of patients at baseline, disappeared in a greater proportion receiving rituximab. In a post-trial observational phase that followed patients for an additional 12 months, the rate of complete and partial remission was higher among patients with rituximab. The urine protein, urine creatinine ratio was lower in the rituximab group, as well as the serum albumin, which was higher in the patients given rituximab. The efficacy of tacrolimus without steroids was demonstrated in a randomized trial of in a randomized placebo-controlled trial of 48 patients from Spain, and one group was randomized to receive tacrolimus at 0.05 mg/kg for 12 months, then with a 6 months taper. And what were the results? The rate of complete and partial remission was higher in the patients receiving tacrolimus at 12 months and 18 months. And the percentage of patients with more than 50% increase in serum creatinine was higher in the patients who were in the placebo group at 12 to 18 months. So this is the Mentor trial, the famous trial that greatly influenced the present guidelines. This is an open label multi-center trial done in North America involving 130 primary MN patients, and they were randomized to receiving rituximab or cyclosporine. At baseline, the median proteinuria of these patients was 8.9 grams per day, serum albumin of 2.5, creatinine clearance of 84.9, but PLA2 receptor antibodies of around 400 units per ml, which places these patients in the high-risk group. The primary endpoints at 24 months was complete remission, defined as less than 0.3 grams per day, and partial remission of reduction of more than 50% of the proteinuria after treatment. So these are the results. Cyclosporine group tended to have remission earlier. At 12 months, 60% in the rituximab group and 52% in the cyclosporine group had a complete or partial remission. And at 24 months, 60% in the rituximab group and 20% in the cyclosporine group had a complete or partial remission. There were more adverse events in the cyclosporine group, and in the PLA2 receptor antibody positive patients, which comprised 74% of those patients, there was faster, greater, and sustained decline in PLA2 receptor antibody levels in the rituximab group. Going back to the patient, we decided to wait and see also for this patient in moderate risk for 6 months, and this was the trend of her UPCR. And after 6 months, her UPCR was still at 4.4 on losartan and atorvastatin. So we decided to give this patient tacrolimus at 0.05 milligrams per kilogram per day. So it is also recommended that after giving treatment, we have to risk assess the patient after 3 to 6 months again. So this is the risk stratification data that will give you if the patient is low, moderate, high, or very high risk for progression of her kidney disease. So after 7 months, the patient on tacrolimus only, the patient, well, tacrolimus with non-immunosuppressive therapy, her albumin rose to 4.2 grams per day, and her urine protein, urine creatinine decreased to 0.5 grams per day. So question number 2, she can be considered in what? No remission, complete remission, or partial remission. So the fellows said complete remission, more fellows said complete remission, and more of the consultants said partial remission. According to the study, their definition for complete remission in the study on tacrolimus was less than 500 milligrams, less than 500 milligrams per day. So it's between partial and complete remission. So how will you proceed with her treatment at this point? The answer of the fellows in training was continue tacrolimus as well as the consultants. So we have seen the usefulness of your PLA2 receptor antibodies in the diagnosis, in the decision to do renal biopsy, in the decision to initiate treatment, as well as the longitudinal monitoring of PLA2 receptor antibody levels at 3 and 6 months. And this is the recommendation to monitor, to evaluate the treatment response of the patient, and to guide us in the adjustment to therapy. So this is their recommendation at 3 months to measure the PLA2 receptor antibodies again. If they're absent, then we discontinue the treatment if they were given rituximab or cyclophosphamide, but continue with your CNI. At 6 months, repeat the PLA2 receptor antibodies. If it's absent or low, continue as per the guideline. However, if the PLA2 receptor antibodies increase, then you may it is recommended that we give an extra dose of rituximab and add cyclophosphamide for those given rituximab. For cyclophosphamide patients, add your rituximab, and for those given CNI, add cyclophosphamide or rituximab. So at 6 months, if the high titers are persistently high or increasing, evaluate and treat as resistant disease. So let us move on now to FSGS. For FSGS, when we see FSGS, it is actually a histologic lesion rather than a specific disease entity. So the lesion of FSGS can be classified into primary, genetic, or secondary. This is a result of many causes, multiple pathways of injury to the podocyte, hence the term podocytopathy in FSGS. And in primary FSGS, it is the putative circulating factor that is toxic to the podocyte, causing generalized podocyte dysfunction. In genetic FSGS, then it is because of the genetic mutations in genes that code for proteins expressed in podocytes and at the slit diaphragm. And for secondary FSGS, it occurs as an adaptive phenomenon that results from a reduction in nephron mass or direct toxicity in the case of drug-induced FSGS. So the presence of an FSGS lesion in a kidney biopsy by itself does not establish a diagnosis, but should initiate an evaluation to identify a specific etiology, since distinguishing between the different forms of FSGS has important implications for treatment and prognosis. So if in a patient with FSGS lesion who is nephrotic, full-blown nephrotic syndrome, it's most probably primary FSGS. So we treat it with immunosuppression, but if no response, we consider genetic testing. However, in patients with a nephrotic range proteinuria, but do not qualify as a nephrotic, full-blown nephrotic syndrome, it is imperative that we exclude or look for secondary causes or genetic forms of FSGS. We do not start immunosuppression in these patients. We just give supportive therapy. But if the proteinuria is worsening and there is a reduction in the serum albumin, then we can consider the possibility of a primary FSGS. So we go to our second case. This is a 22-year-old male who presented with a nephrotic syndrome and biopsy-proven FSGS with the TIP variant at age 15 years old. So he has a strong family history on the paternal side. His uncle had FSGS, underwent a KT. 2 uncles had renal cell CA, a cousin had SLE, and an aunt had Sjogren's syndrome. This was his UPCR back in 2013 when he was 15 years old. So in patients with primary FSGS, it is recommended that high-dose oral corticosteroids be used as a first-line immunosuppressive treatment for primary FSGS that should be continued until complete remission or as tolerated up to a maximum of 16 weeks. And if they respond to corticosteroids, then the corticosteroid should be continued for at least 6 months. So in adults with relative contraindications or intolerance to corticosteroids, alternative immunosuppression with CNIs should be considered as an alternative initial therapy. The goal of therapy in primary FSGS is remission of proteinuria, preferably complete remission. And the strongest prognostic indicator of renal survival is the initial response of the proteinuria to therapy. So it is very important that on follow-up, we determine if the patient how the patient responded to the initial therapy. So complete remission is defined as less than 0.3 grams per day or a serum, stable serum creatinine with stable serum creatinine. Partial remission is 0.3 to 3.5 grams per day and a decrease of more than 50% from baseline. You consider a patient to have relapse if there is nephrotic range proteinuria and an increase in proteinuria of more than 50% during partial remission. The patient is also considered treatment-resistant, corticosteroid or CNI resistant if there is persistence of nephrotic range proteinuria with a less than 50% reduction from baseline despite adequate treatment. And they are also corticosteroid or CNI resistant if they relapse during or within 2 weeks of completing the treatment or while tapering the treatment. So let us go back to the case. And as you can see here, early on, he was steroid dependent because initially he was given methylprednisolone and cyclosporine. He was initially seen to be steroid dependent because if you will see here, while tapering the steroids and the cyclosporine, the patient would have a relapse. So again, he would be given steroids. The same thing, whenever there would be tapering of the steroids, because there's a remission, he would again have a relapse. So this patient at this point was transitioned to adult nephrology. And so we decided to give him, instead of methylprednisolone, prednisone at 1 mg per kg. But as you can see here, after 3 months, we did not see any improvement or remission in his proteinuria. Therefore, we label this patient as having corticosteroid-resistant primary FSGS, and it is recommended that we give cyclosporine and tacrolimus for at least 6 months rather than continuing with corticosteroid monotherapy or not treating at all. So adults with corticosteroid-resistant primary FSGS who respond to CNI treatment should receive a minimum of 12 months. However, if they are corticosteroid and CNI resistant, they should be referred to specialized centers for rebiopsy, for alternative treatment, or subsequent need for further immunosuppression. So what happened to our patient? So as we have said, we gave him, at this point, we gave him tacrolimus. And as you can see, as the months went by, nothing happened. That's why nothing happened. So we deemed this patient to be steroid and tacrolimus and CNI resistant. So in this patient, what is the next step in the management? The fellows and the consultants as well would do a rebiopsy, and they would opt to give alternative therapy depending on the results of the biopsy. But very few fellows and consultants would do genetic testing. So what is the role of genetic testing in this particular patient? Well, these are the two important considerations. At this point, we wanted to know whether we need to stop immunosuppression anymore and limit immunosuppression, because if this is genetic FSGS, almost all genetic FSGS are really resistant to treatment. Another reason is to determine the risk of recurrent disease in kidney transplantation, because the plan is, if this is a patient with genetic FSGS, then we will discontinue treatment, allow him to go to ESRD, and do kidney transplant, which is the definitive treatment for genetic FSGS, because it is not, because it does not recur. Genetic FSGS does not recur in the transplant. So these are the alternative therapies for FSGS, and as you can see here, there are limited data that would prove benefit for these agents. So what happened to the patient? We repeated the biopsy, and it still showed primary FSGS, this time cellular variant with features of CNI nephrotoxicity. We also did a genetic testing with this patient, but he was negative for genetic mutation. So we gave him another chance and gave him alternative treatment of MMF for 4 weeks with no response. We tried rituximab for 2 doses with no response also. So we decided to just stop all immunosuppressives, and after 8 months, we started him on peritoneal dialysis. And we are preparing him now for KT. So what else can you offer for this patient? So many of the fellows, more fellows would just continue with PD, and more fellows would do living KT, but the consultants, more consultants would do deceased donor. But we have to bear in mind the risk factors for recurrence of FSGS, childhood onset of the initial disease, which our patient has, and the recurrence rate of FSGS is 20 to 30% in the first renal transplant and is more than 80% in subsequent allografts. I think that's my last slide. I would like to thank Dr. Shari Ansi Atanasio for helping me with the research, for editing my slides, and for putting more sense in the flow of my discussion. Thank you very much for your attention.
Good evening. I am Dr. Russell Villanueva. I will continue the discussion on the new clinical direction on the management of glomerulonephritis. I'll be presenting 2 more glomerular diseases. We'll start with a case, a 21-year-old male who was referred to your clinic due to abnormal urinalysis. He's non-diabetic, non-hypertensive, and when you check the urinalysis, the protein is +4, and RBCs of 40 to 50 per high power field. Serum creatinine is 106, and the 24-hour urine protein was measured at 2.2 grams. On renal biopsy, it was read as IgA nephropathy with the following MEST score. IgA nephropathy is the most common glomerular disease worldwide. In the local registry done in the Philippines, 35% of the biopsy cases was read as IgA nephropathy. In this study, in partnership with Tan Tock Seng Hospital of Singapore, it was noted that the Philippine cohort have younger patients and lower serum creatinine upon presentation in the clinics as compared to the Singaporean group. IgA nephropathy has been discussed in many forums as well as in articles, but I'd like to go back in the early 80s in this article done by Dr. Rodicio of Spain. Back then, it was estimated that the risk of end-stage renal disease is 20% in 20 years. So Dr. Rodicio made a conclusion that IgA nephropathy follows a benign course, that it would not need any treatment with steroids or any immunosuppression. Now let's discuss prognostication. In the study done in the Philippines at the National Kidney and Transplant Institute, wherein it enrolled 206 IgA nephropathy cases and review of records with a follow-up of a mean of 2.9 years, it was discovered that around 30% of these IgA nephropathy cases had either a doubling of serum creatinine or had a more than 50% increase in estimated GFR from baseline. And sadly, 15% in that 3-year observation period underwent renal replacement therapy. So there are a couple of predictors of poor outcomes in IgA nephropathy, but with robust evidence is particularly proteinuria and GFR at presentation. Now, when do we become more aggressive in managing our patient? Is it the time that proteinuria presents, or when the GFR goes down, or when the patient's already in chronic kidney disease? Proteinuria seems to be an important biomarker with regards to prognosis in IgA nephropathy. It follows a linear relationship with the level of proteinuria and the deterioration of GFR in both male and female patients. Another prognostic tool that is easily replicated is the Oxford MEST classification, which was shared to us in 2009. So the MEST score includes mesangial hypercellularity, endocapillary proliferation, segmental glomerulosclerosis, and tubulointerstitial fibrosis. But as studies became more available and a review has been done, they noted that CRESCENT is also a good factor to consider with regards to prognosis. And thus, in 2016, they revised the Oxford score and now has been known as the MEST score. The MEST score is important with regards to giving prognosis to your patient, but they have also devised a decision tree for patients with IgA nephropathy, not only including the level of proteinuria, but also the MEST score on whether you're going to give immunosuppression, corticosteroids alone, or corticosteroids with another cytotoxic. Important to note also, individually, the MEST score has some value with regards to prognosis, with regards to response to treatment, and also predictive of worse outcomes. In 2019, during the World Congress of Nephrology held in Melbourne, Australia, this was presented, a new international risk prediction tool in IgA nephropathy. So if you have the Calculate app by QXMD in your phones or in your tablets, just look for the International IgAN Prediction Tool, wherein you have to plot in 12 variables, the demographics, lab findings, physical exam, and the use of certain medications. Now, when you're able to put in the numbers, it will be able to provide you a risk of renal progression, maybe even a 5-year risk horizon. With regards to treatment, I've asked in a survey that I shared with our consultants and our fellows in training, I asked, among the following treatments commonly used in IgA nephropathy, which one has the highest level of evidence for benefit? So most of the consultants answered ACE inhibition. The fellows in training also answered ACE inhibition, but a good number of them answered corticosteroids. So they have to review IgA nephropathy. So as of today, there is no drug approved for the treatment of IgA nephropathy. But based on KDIGO guidance, the one that is effective as of now is ACE inhibition or angiotensin II receptor blockade. It is the only one with a 1B recommendation. The rest has a 2C to 2D recommendation, meaning a low to very low level of evidence. I shared the case in the survey. Which of the following IgA nephropathy cases warrants the immediate treatment with corticosteroids? Is it selection 1, which is a case of nephrotic syndrome? Selection 2 is a patient with persistently elevated serum creatinine. Selection 3, patient with a subnephrotic proteinuria with stable renal function. Or the last selection, with patient with isolated hematuria. So most of our consultants answered the patient with nephrotic syndrome. Same with the fellows in training, but a good 20% of our fellows in training would give steroids to the patients with isolated hematuria. Let me share with you an IgA nephropathy treatment algorithm. So based on this algorithm, the patient with nephrotic syndrome would warrant immediate treatment with immunosuppression on top of supportive therapy. Aside from cases of nephrotic syndrome, those who presents with crescentic glomerulonephritis. Now, the selection for isolated hematuria, it is considered low risk. So you don't have to give corticosteroids, but you just have to monitor this patient once or twice a year for the next 10 years. For the other two selection, you first have to give supportive therapy, be it diet or maximum RAAS inhibition, then later decide on whether you're going to give steroids. So for example, if the GFR is less than 30, then this patient should be managed as a case of a chronic kidney disease. But if the GFR is more than 50 and the proteinuria is still above 1 gram per day, then you could consider a 6-month course of corticosteroids. Corticosteroids has been reviewed extensively in the treatment of IgA nephropathy. So in this study done by Kobayashi in 1996, steroids has been able to have a positive outcome with relation to the doubling of creatinine from baseline. So that is why steroids has been a popular drug that has been used for IgA nephropathy therapy. Later on, another study done by Ballardi, now particularly focusing on patients with progressive IgA nephropathy. He gave the patients prednisolone plus cyclophosphamide for 3 months and later on a maintenance from 2 to 6 years with azathioprine. The outcome, 5-year renal survival, and you would see on the graph at the bottom, it is positive results with those who receive treatment. And thus, KDIGO, although a grade 2D was given, that cytotoxics may be useful in patients presenting with a rapidly progressive GN or a crescentic IgA nephropathy. A lot of criticisms have been given to these studies in IgA nephropathy in the early days because the trial sizes were small and there were issues in design. So in December 2015, it was published the STOP-IGA nephropathy trial, or the STOP-IGAN trial, which is considered a landmark with regards to this particular glomerular disease. So this study enrolled 337 patients with biopsy-proven IgA nephropathy with significant proteinuria and hypertension and an estimated GFR between 30 to 90 ml per minute. So they underwent a run-in phase of 6 months being given the maximized RAS inhibition. And by the time that the run-in is finished, 162 patients remain to be eligible for the study. It's important to note that just giving maximized RAS inhibition have provided improvement in most of these patients, thus the decrease in numbers from baseline after and also compared to the numbers after the run-in. Now, the 162 cases were randomized to either receive supportive therapy or immunosuppression. The outcome is a co-primary outcome with regards to decrease in proteinuria and also the decrease in GFR. So the co-primary outcome, they have to have positive results in both, and thus investigator deemed that there was no statistically significant difference between immunosuppression therapy and supportive care. Sadly, also, those who receive immunosuppression have higher rates of adverse events. Focusing on full clinical remission, of course, those with immunosuppression fared better. But if you review the final disposition of this study, those with progression is just equal for those on supportive care versus those on immunosuppression. Also, focus on adverse events. Numerically, there were more infections in the immunosuppression group, and there is also statistically significant difference with regards to the occurrence of impaired glucose tolerance or diabetes mellitus in patients with immunosuppression. So the authors conclude that the immunosuppression did not achieve the co-primary outcomes set by the research team. There were more adverse effects with immunosuppression. Also, we have to note that progressive loss of estimated GFR is just the same in the treatment group and the control group. So they want to know more of what happened to the population in the STOP-IGAN trial. In the ERA EDTA earlier this year, this study was shared, and until they have a complete paper, we could review it. But with regards to the graph, you could see that there is no difference with regards to the long-term endpoint of death, end-stage renal disease, and estimated GFR loss, whether you are in the immunosuppression arm or the control group. Now, the years have come where we began to understand the pathophysiology of IgA nephropathy. So no single mechanism or factor can be the one that attributed to the occurrence of the disease. It has to be interaction of different factors or a cascade of different events that leads to the development of disease. Now, because of this, we need to target a targeted therapy with regards to the treatment of IgA nephropathy. So it has to be something that addresses all the factors, be it immune complex formations, local inflammation, and as well as hemodynamic injury and final pathway to fibrosis. So as you can see, different drugs can address the problems that is brought about by the mechanisms of IgA nephropathy. But recent clinical trials have focused on the following: mucosal immunity, B-cell activation, mesangial cell activation, and complement cascade. So allow me to share with you some recent trials with regards to IgA nephropathy therapy targeting these factors. So with regards to mucosal immunity, one study that was published in March 2017, the NEFIGAN trial, a placebo-controlled randomized trial, phase 2B, uh, using a targeted release budesonide compared to placebo. So this targeted release budesonide, that the drug would release its active components while it is in the vicinity of the ileum. So there will be an interaction between the drug and the pairs patches because they believe that the pair patches may be releasing the abnormal galactosylated IgA antibodies. So the results in 9 months seems to be positive with regards to the mean average of the routine protein creatinine ratio as well as the mean average of the estimated GFR. But there are more patients who withdrew from the study that were taking the medication as compared to the placebo group. Another survey question that I asked, mycophenolate has been studied for the treatment of IgA nephropathy. So based on recommendation, which of the following groups should receive the drug? So is it patient who have nephrotic syndrome, patient who cannot tolerate steroids, patients with Chinese lineage, or patients with isolated hematuria? So mycophenolate MOFETIL has been studied all over the world. There were studies in the US, the Belgium, and a lot of studies in China. But in the studies in the US or even in Europe didn't show any positive effect of mycophenolate in the treatment of IgA nephropathy. But there are studies done in China, this one from Hong Kong, that shows that patients treated with mycophenolate would provide better outcomes as compared to those not being treated with the drug. And that is why that we expect recommendations soon that mycophenolate MOFETIL would be advised to be given to patients with Chinese descent. Beta cell activation is also reviewed as a target for treatment of IgA nephropathy, and one drug is Rituximab. So there are a couple of studies that were done in Rituximab, this one published in JASN, and there was no statistically significant difference with regards to the plot of estimated GFR change with the medication. Another popular target of experimental drugs is complement. So eculizumab is a popular drug, and it's a monoclonal humanized antibody to C5. So here, I'm just sharing some studies wherein eculizumab was used for the treatment of IgA nephropathy, but there is still no strong evidence because only a small number of trials and small subjects were enrolled using this drug in IgA nephropathy. And one barrier is this is considered one of the most expensive drugs in the world. So you could just imagine one vial would cost close to ₱1,000,000. So I don't think this will take off in our third world country. Other studies are sponsored by Achillion, targeting factor D in the complement, and also a study done by Novartis. So let's go back to the case. Do we treat the patient that I shared earlier? Of course. But do we give immunosuppression? Maybe we have to discuss because the benefit and risk have to be balanced with regards to our patient's management. So we have to cover the basics first. We provide BP control, maybe target a BP of 120/80, maximize the RAS inhibitors, consider fish oil. I would give fish oil, though it is low reward, but there is low risk in its use. And maybe in some centers abroad, they will provide or advise the patient tonsillectomy. We have to consider clinical features and rate of progression and biopsy features before we decide if we will be very aggressive in the management of our patients. But if we do decide to proceed, for now, glucocorticoids is the most convincing option. Maybe cyclophosphamide if you diagnose the case or the histopath read as severe crescentic GN, or as mentioned earlier, MMF if the patient has Chinese lineage. But for us to advertise, Dr. Andres and I have been doing clinical trials in IgA nephropathy. We do recommend that you enroll your patients with IgA nephropathy in clinical trials because as mentioned, there's still no drug approved by the FDA for IgA nephropathy, and maybe enrolling them in clinical trials will discover a drug that could be very beneficial with low adverse events profile that we could provide our IgA nephropathy population. The second case that I'll present is a 27-year-old female who was referred for co-management due to elevated serum creatinine. So patient was already diagnosed with SLE in 2015, already given hydroxychloroquine and steroids, but the patient has poor compliance. So she was in my clinic in January of this year, and her serum creatinine was already 176. Very active urine sediment. I advised renal biopsy, and the results showed that the patient has, of course, lupus nephritis with an ISN-RPS class 3 and mentioned activity index and chronicity index. So this is a case of lupus nephritis. So we know that LN is quite heterogeneous and a difficult to treat disorder, which presents a serious clinical challenge for us. Based on its pathophysiology, there is immune dysregulation that involves both the B and T cells, and thus that we have to target multiple aspects of the immune response using combined immunosuppressants. So despite improvement in management and new drugs available, still becomes a major challenge for us in the treatment because LN increased the risk of end-stage renal disease and deaths among the SLE population. So again, in the area ETA, Dr. Morani, who's an expert in lupus nephritis, shared a study on monitoring the one-year response using the EULAR or ERA-ETA response at 1 year. So he defined complete response as proteinuria of less than 0.5 grams in 24 hours and near normal estimated GFR. Partial response was defined as a more than 50% reduction in proteinuria to subnephrotic levels, again with near normal GFR. And the rest of the cases has no response, and the renal outcome that they measured is chronic kidney disease. So in 1 year, using the standard therapy for lupus nephritis, 58% had complete response, 26% have partial response, and 16% has no response. So they followed the different groups from a long timeline for almost, I think, 20 to 25 years, and shows that those with complete response have a 96% of CKD-free survival. Partial response, 95%, but those with no response in 20 years, the chances of being CKD-free is just 43%. Thus, the new clinical direction, we have to achieve a rapid response to therapy. Also, we have to treat refractory forms of lupus nephritis and avoid relapses. And it's also a dream to eliminate the use of corticosteroids. Sadly, the lupus nephritis cases, we know that all SLE patients have a risk of progression to end-stage renal disease of 10 to 30% within 15 years from diagnosis. A lot of studies have been done, and you see that some of them have been failed or have been terminated because the results weren't promising. So with the new KDIGO 2020 guidelines, we would see new recommendations in the treatment. One particular is the recommendation that for patients with SLE and lupus nephritis, that they be treated with hydroxychloroquine. And this is because of two important studies, the GLADEL trial for the Latin American population and the RELACER trial for the Spanish population. And they've seen that the odds ratio for lupus nephritis, odds ratio for end-stage renal disease, and odds ratio for complete response to lupus is better with regards to the use of hydroxychloroquine. So it's a must that all patients should receive this medication. Now, focus on the different lupus nephritis class, this one for class 1 and 2. So if the patient that you did a biopsy has this for a reading, so check the level of proteinuria. So if it's just a low level proteinuria, you would only give immunosuppression that is warranted for extrarenal manifestation of SLE and nothing more. But if the patient has nephrotic syndrome, then the patient might have some form of lupus podocytopathy. Then you treat this patient as if the patient has minimal change disease. So it's prednisone 1 mkd for 6 months and a very slow taper for another 6 months. But also consider adding another immunosuppressive agent to the patient suffering from nephrotic syndrome. Class 5, which is membranous lupus nephritis, So again, check the proteinuria. So it is warranted that you give RAS blockade, hydroxychloroquine, and of course immunosuppression that is only warranted by extrarenal manifestation of SLE. But if the patient has nephrotic syndrome, then it's immunosuppression with glucocorticoids plus one more immunosuppressive agent. Now, let's talk about the active proliferative type of lupus nephritis. So for this patient, it is advised that you give methylprednisolone pulsing of 0.25 to 0.5 gram per day for 3 days, followed by oral prednisone of 0.6 to 1 gram per day, then provide a tapering schedule. Then you add another drug. So first present the cyclophosphamide group. So the cyclophosphamide group has different regimens. So can be given per RM with the tablet if it's available. But if you're going to give it IV, you could either give it monthly or every 2 weeks for 6 doses. On the other side, you could also have an option to give mycophenolic acid analogs. And if you're going to use mycophenolate MOFETIL, you should use the drug dosing of 2 to 3 grams per day for the next 6 months as part of the induction. And now, a popular one is the multi-targeted therapy using lower dose of CNI and lower dose of mycophenolic acid on top of steroids for our patients with active proliferative GN. So this is a question that I posted again, and these are the options, and most of our consultants answered that they would shift to a multi-targeted therapy, but it's opposite for our fellows. They would choose to just lower the mycophenolate dose. So it's ideal that you start the patient with multi-targeted therapy. So the multi-targeted therapy in studies use tacrolimus at 2 milligrams per day and mycophenolate at 1 gram per day on top of prednisone. So in this study, published in JASN in 2017, the multi-targeted therapy provided more patients with complete response and total response, which is complete and partial response, as opposed to IV cyclophosphamide. Adverse events were just the same for both. So now you might ask, what's the best induction therapy for lupus nephritis? So in this study done and published in Cochrane, has shown that the combination or the multi-targeted therapy seems to be more effective than IV cyclophosphamide as compared to CNI or MMF alone. Now, there's another CNI that's being studied, and in preclinical observation, it's believed to be more potent and less toxic. And you don't even have to do drug monitoring like cyclosporine because its pharmacokinetic is stable. Evidence show that it provides good remission, but it has more serious events. So that is something that we still want to observe in future studies with this CNI. Now, for the maintenance phase of lupus nephritis, then the recommendation now is to give mycophenolic acid analogs at 1 to 2 grams per day. For those considering pregnancy, give azathioprine, but those patients who can't tolerate both drugs, give calcineurin inhibitor. So the next question I posted, what's the recommended total duration of treatment of lupus nephritis? So most answered 1 to 2 years, but actually the correct answer is 3 years. The total duration of induction of immunosuppression and maintenance therapy should not be less than 36 months. Now, for refractory forms of lupus nephritis, it is something that we have to address because it provides a major risk factor for renal function deterioration in the future. So this is further proof that flares can lead to problems in the future because those who develop flares have less renal survival based on doubling of serum creatinine. And that's why anti-B-cell therapies has been proposed for lupus nephritis. Fortunately, one trial, the LUNAR trial, it's the largest RCT that evaluates Rituximab as an intervention for lupus nephritis. There was no difference between placebo and treatment group, and though adverse events and serious adverse events were similar in both groups. But in further review, post hoc analysis of the LUNAR trial, it shows that those who achieve complete depletion of B cells have better response. So maybe we could just adjust the medications to provide or monitor the B-cell response to lead us to better treatment response. So my final take on lupus nephritis that the multi-targeted therapy can be used in patients with severe forms of lupus nephritis, particularly in the presence of high proteinuria. Rituximab can be a drug of choice in patients with refractory form of lupus nephritis. So I hope that Dr. Andres and I were able to share with you the new clinical directions on the management of glomerulonephritis. Thank you for your kind attention.
Thank you very much, Dr. Andres. So the floor is now open for questions from our attendees. So, Dr. Villanueva, maybe we can ask you a lot of the questions. The first few questions were on IgA nephropathy and lupus nephritis. So the first question is, Dr. Ras, are you there?
Yes.
Okay. So how long do you give immunosuppression for high-risk IgA nephropathy, and what is the target endpoint?
So for now, I'll target for a 6-month course and evaluate. And the target endpoint, of course, is delay the progression or any progression. Best if you could lower the proteinuria to less than 1 gram per day and have a stable renal function. So for me, that is the goal.
So at least 6 months, right? Okay. So the next question, again on IgA nephropathy, is there still a role for fish oil in the management of patients with IgA nephropathy, and what is the recommended dose?
So there are good studies that were done in the 90s in fish oil, particularly a study done in Mayo Clinic that showed benefit of using fish oil. But unfortunately, after a few years, there's another study that shows that there might be more harm in giving fish oil. And finally, there was a meta-analysis that there is benefit with fish oil, but minimal benefit. So for me, I would still give it, but do not expect a lot. So it's low reward, but also low risk for any adverse event. Now, the recommended dose still based on study is 4 grams to 12 grams per day, divided in 2 to 3 doses.
Okay. So the next question is on lupus nephritis. Again, for Dr. Ras, any comment on the use of rituximab for pregnant patients with lupus nephritis?
So rituximab is considered class C with regards to adverse events, particularly in pregnancy. So I would not advise because on animal studies, it shows some fetal effects that were not good. So not recommended for now.
Okay, so I think Dr. Ras mentioned in his lecture the alternative for maintenance therapy that you can shift to azathioprine for pregnant patients. Yeah. So yeah, next question is for again for Dr. Ras. When do we give multi-targeted therapy? I think this is based on your the data that you showed for low-dose CNI with mycophenolate on refractory lupus nephritis, or can it be started immediately once lupus nephritis 3 or 4 is established? So when do you choose to give the multi-targeted therapy?
You could actually give it already as your induction therapy. As mentioned in my final slide, particularly with severe lupus nephritis and with heavy proteinuria, I would prefer to give the multi-targeted therapy. Now, for refractory lupus nephritis, the advice is to give the treatment that you gave during induction where you saw improvement. But again, now it's being recommended that maybe giving rituximab is an option.
As a follow-up to that question, so the multi-targeted therapy, I think, is as an alternative if the patient is is intolerant to the usual dose for induction mycophenolate. Is that correct, Dr. Ras?
That is correct. So if they cannot take the cyclophosphamide, the mycophenolate at their usual dose for lupus treatment, then the low-dose CNI and low-dose mycophenolate in the multi-targeted therapy or the multi-therapy is recommended.
Okay. We have a question for Dr. Steph. So you mentioned a lot of things about this promising test, which is the PLA2 receptor antibody, but is it available in the Philippines?
Unfortunately, it is not available in the Philippines, but
so we send it out to where?
Yes, we send it out. Yes, the closest country where it is available is Singapore, and I asked already how much it costs. It's just 120 Singapore dollars, so it's roughly 4,300 pesos. And the courier, if we send it through courier via DHL, it's around 900 pesos, so 1,000. So that's about 6,000. Yes, so maybe it would be more cost effective. In lieu of doing the biopsy, which costs how much now? 35 to 50,000. If you are really, if you have a patient with nephrotic syndrome and a possible membranous as part of your differential diagnosis, probably for my next patient, I would try requesting for your PLA2 receptor antibodies. It has revolutionized, actually, your PLA2 receptor antibodies has revolutionized our management of membranous nephropathy. First, as we have said, in the diagnosis. Second, in the decision to do renal biopsy. Third, to initiate therapy, as well as to monitor treatment, and as well as prognosis. Patients who had significantly decreased levels of PLA2 receptor antibodies on follow-up have been shown to have very good prognosis and prolonged remission rates. So it's very useful. That's the recommendation.
Right. So just to reiterate from your lecture, if a patient has low-risk features and clinically compatible with membranous nephropathy, then you can do away with the biopsy and just do a PLA2 receptor antibody test.
That's correct. That's correct.
Yeah. Okay. Now we have another question for Dr. Russell. So in lupus nephritis 3 to 4, is an ACE inhibitor or ARB still indicated on top of the MMF and CNI?
I think it should be given to these patients, particularly if they exhibit considerable proteinuria and also increase in blood pressure. There will still be my first line medication, particularly for that indication in lupus nephritis. So I will still give them.
Yes, okay. Next question is for Dr. Steph, asking about, this is probably, so for FSGS, there are reports of collapsing glomerulonephritis, collapsing variant of FSGS as a renal manifestation of COVID. Being a country with a very high incidence of COVID, would you consider testing for it as part of routine workup to look for a secondary cause of FSGS?
Well, now that during the COVID era, I think it would be more prudent to really request for it if you find collapsing FSGS on your biopsy. Another cause of FSGS now is HIV, but as we have learned in the past, HIV collapsing FSGS because of HIV is not so common among Filipinos. So now that we are in the COVID, I think we should request for COVID testing for collapsing FSGS.
Okay, so that would mean that it's a secondary or infection related glomerulonephritis, and the treatment would be to treat
the cause.
Systemic.
Yes. Okay.
So for Dr. Villanueva, would you give mycophenolate to your Filipino, not of Chinese descent patients with IgA nephropathy presenting with proteinuria?
Of course, I will first give steroids, and if the patient is not able to tolerate steroids, then that is an option that I could give but it will be nice if we have local data with its use. So maybe in the future.
So again, just reiterating from your lecture, the most data or the evidence for treatment of IgA nephropathy, if we do consider immunosuppression, is still corticosteroids, right? Okay, so we go on to another question for Dr. Andres. What treatment regimen would you recommend for a high-risk membranous nephropathy patient with active Hep B infection and elevated liver enzymes? So most likely this is secondary membranous nephropathy.
So for hepatitis B, if the patient has hepatitis B, probably with high ALT, maybe it would be more prudent also to treat the cause. If you are really convinced that this is secondary, treat the cause, treat the hepatitis infection, and monitor the patient after closely monitor the patient after 3 months and 6 months. Because giving immunosuppressive therapy would make the patient worse, would make the hepatitis infection worse.
So treat the systemic cause, and on top of that, the usual management, which is diet and gas blockade, right?
Yes.
Right. So another question for Dr. Villanueva. Thank you for the informative lectures. My question is regarding patients diagnosed with lupus nephritis 3 to 4 who underwent multi-targeted therapy induction with CNI and MMF. Do you or the upcoming guidelines recommend maintaining the CNI throughout the maintenance phase? I think they maintained it in the study, but I do not recall if the RCTs with CNI and MMF versus MMF alone, nor the analysis or comments regarding this.
So currently, the preferred maintenance therapy would be MMF. But if you're not able to tolerate MMF or azathioprine, then that's the time that you could be maintained on a calcineurin inhibitor.
But the maintenance phase, do you still combine low dose MMF with CNI, or do you just continue the maintenance phase with the CNI alone?
You just if you use the multi-targeted therapy, you just maintain the MMF with low dose steroids, because you're gonna give this for to complete the 3 years of therapy.
Okay, so induction with low dose CNI plus MMF, but the maintenance phase for a minimum of 3 years should be composed of MMF, steroid, and of course hydroxychloroquine, correct?
Correct.
Okay. Next question. Okay, so I guess it can be directed to both of you. This question is asking about glomerulonephritis that is treated with tacrolimus. Do you monitor the serum levels for those treatment regimen that includes tacrolimus?
I could answer, Steph.
Okay.
With regards to lupus, we use the low dose, but I got to talk with an expert from Hong Kong, Dr. Daniel T.M. Chan. He prefers a lower target trough if you're going to monitor the drug levels of 3 to 5, because we know that there is CNI toxicity. So if we're going to monitor the levels, then we target around 3 to 5 nanograms per milliliter.
Russell, excuse me. I think for membranous and FSGS, the recommended target trough levels is 5 to 10 nanograms per ml for these patients. But of course, you also have to monitor the eGFR, the GFR of this patient, the serum creatinine, because we will try to avoid tacrolimus if the eGFR is less than 30 ml per minute per ml per minute. So try to avoid it and try other alternative treatments instead of tacrolimus or another CNI, cyclosporine.
So Dr. Steph, in case your patient is the GFR drops to less than 30 and the tacro trough is still not up to the recommended levels, what do you do then?
Well, actually, Actually, it is already contraindicated if your GFR is less than 30. So opt for other treatments for that GN.
Okay, so you give alternative regimen
Treatment.
for those with GFR of less than 30.
Yes.
Okay, another question. So for Dr. Ras, in areas with no kidney biopsy, do you recommend steroids on top of conventional therapy in high-risk IgA nephropathy? So I guess they're asking for shotgun therapy because of the lack of resources for kidney biopsy.
So we do understand that will be difficult, but again, it's difficult to give steroids in IgA nephropathy as shared by the STOP-IGAN trial, that the risk is higher than the benefits. So I prefer to give steroids if I really know if the patient has IgA nephropathy. Maybe if the patient seems to be exhibiting like a podocytopathy, nephrotic syndrome, then a trial of steroids can be warranted. One particular GN that you don't need biopsy and you could start steroids is minimal change disease if it's suspected, particularly in the pediatric age group. But again, we have to be careful if not having any biopsy because the drugs are not 100%, it's not safe. There are side effects that we have to worry about.
Okay, next question for do you recommend trough level for tacrolimus in lupus nephritis and mycophenolate drug level also in multi-targeted regimen? I think we've covered that part.
I think I answered the tacrolimus. With regards to the mycophenolate, in some countries, they do measure the drug levels, particularly because there's less side effect if we have a certain target, but I don't think it's available locally. So I already answered with regards to the trough level.
So it's usually 1 to 2 grams of mycophenolate, correct?
It's 1 gram for the multi-targeted therapy because they want to give a lower dose because you're giving CNI concomitantly.
Okay. So for Dr. Steph, for patients with primary FSGS and no genetic testing done, and just like the case which seems to be multi-drug resistant nephrotic syndrome, is there a role for extracorporeal therapy since a good percentage of FSGS patient is immune related? So maybe they're asking for plasmapheresis?
Yes, that's right. So plasmapheresis can be given to these patients because precisely for primary nephrotic syndrome, it's the permeability factor that is circulating that causes the problem, the podocytopathy. But there is only limited experience, as we have said, for plasmapheresis in patients who underwent KT and had recurrent kidney transplant. So most of the experience for plasmapheresis is for those recurrent FSGS after transplant. Yes.
Okay.
But definitely it has a role. But I was thinking it will just decrease your permeability factor at the time after plasmapheresis, but it will not really cure the disease, right? It will just stabilize you that every time you would do the plasmapheresis, you decrease the levels of your permeability factor. But after it will up again, and you need to do plasmapheresis again as you do dialysis, maintenance dialysis. We had the patient. Yes, we had the patient before, but the experience that I had for plasmapheresis is after KT, precisely after KT, and we were able to. The patient was able to be maintained on plasmapheresis 3 times a week for a period of 3 years, and her creatinine was stable for the next 3 years on plasmapheresis 3 times a week.
3 times a week.
Para rin siyang nag-dialysis after her KT.
Pero magkano yun? 3 beses siguro yung mahal sa...
Yeah.
Okay. So for Dr. Ras, so you mentioned about alternatives to IgA nephropathy treatment aside from steroids. A question is asked if tacrolimus can be part of the management if the patient is not responding to steroids or MMF.
Present recommendation hasn't included CNI yet. But there were studies that were done. Some didn't show any positive results. So maybe if we have larger studies, maybe we find an answer in the future.
Another question for Dr. Steph. What is the recommended immunosuppressive agent for FSGS patients desirous to get pregnant?
Well, if you desire to be pregnant, then I think you can use, of course, your corticosteroids, your CNI, can be given in patients who are pregnant.
The CNI?
Yes. The Rituximab, I think, as Dr. Russell mentioned earlier, there are no studies yet that, this category C, there are no studies yet that it can be used in pregnant patients. But steroids and tacrolimus can be used in pregnant patients.
Of course, if the patient is responsive to steroids alone, then you can just continue with this.
Exactly. Yes.
Okay. So Dr. Danny Yu congratulates the both of you for top-notch lectures. He asks, historically, chlorambucil was used for membranous nephropathy. So whatever happened, why is it not in the regimen anymore? And should we continue hydroxychloroquine in lupus nephritis with nephrotic syndrome?
Well, chlorambucil is a cytotoxic drug that has many side effects, many adverse effects. I think that's the main reason why it is not included in the recommendations anymore. I had a personal experience with chlorambucil in a patient with membranous. I will never give it again to any of my patients with membranous. Very bad side effects, especially infection, severe infections.
Dr. Russ,
Okay.
a question for lupus nephritis.
So for lupus nephritis, sorry, I can't find the question again. Can you repeat?
If you could still, or you should you maintain the hydroxychloroquine for nephrotic
Okay, got it.
proteinuria for lupus patients?
So current recommendation, they have to be maintained. As long as you have lupus nephritis, you should be on HCQ.
Okay. Dr. Steph, is genetic testing for FSGS available in the Philippines?
No, it is not available. We had, for this patient, we had to do it, we had to send the specimen into the US. We were fortunate that this patient has the means. Actually, honestly, we were able to do these tests because I was co-managing this patient with Dr. Adrian Liu from Singapore. So he facilitated that the specimen be brought to, their blood specimens be brought to the US for genetic testing. This is a very difficult case, and the geneticists in the US were all scratching their heads. What kind of FSGS is this? So resistant to all the treatments.
Okay. So would PLA2 receptor antibody be able to distinguish between primary and secondary membranous nephropathy?
Yeah, very good question. Actually, it cannot distinguish between primary and secondary because, as we have said earlier, it is possible that for patients with primary MN with positive PLA2 receptor antibodies, it is possible that there are concurrent diseases, infections, cancer, or the autoimmune diseases can be present also. So it is more for primary. PLA2 receptor antibodies is more for primary membranous nephropathy.
Okay.
But you know what? Sorry. There's another note regarding your PLA2 receptor antibodies with MN. It can be a precursor. Well, as we have said, the thrombospondin associated with cancer. And there are patients who have membranous, for example, even without doing the PLA2 receptor antibodies, they seem like they're primary MN on biopsy, but later on, these patients can develop cancer. It could antedate cancer in some cancer patients with MN. The renal manifestations of MN can antedate cancer. That's why for elderly patients whom we biopsy, nephrotic syndrome elderly patient, we biopsy them, seems like primary MN, we should negative cancer workup at the moment. We should still follow them up in the future because it's possible that later they will be positive now for their cancer.
Okay, much as we want to answer all your questions because we're getting a lot, we're pressed for time, so we will just entertain 2 to 3 more questions, but maybe we will get all the other questions that have not been answered, and we will ask Dr. Steph and Dr. Russell and have the PSN Secretariat send you the answers to the question. So another question, Dr. Steph, so you mentioned in primary FSGS, if the patient is resistant to steroids, you can give a CNI as an alternative. Yes. The question is, what is the usual dose in which you start the cyclosporine or tacrolimus for primary FSGS?
For cyclosporine is 3 to 5 milligrams per kilogram per day. We also try to maintain a trough level of 100 to 175 nanograms per ml. And for tacrolimus, it's the same, 0.5 to 0.1 milligrams per kilogram per day, divided into 2 doses. Target trough levels 5 to 10. I think it's interesting because Russell said that for lupus nephritis is 3 to 5, the recommended is 3 to 5. By experience, those recommendations are based on studies done in Caucasians. So among Filipinos, among Filipinos, we try to target the lower end of the level. So I think 5 would be pretty much safe for these Filipino patients. Yeah.
Okay. Dr. Russ, how do you go around patients who cannot tolerate prednisone due to cosmetic factors but would really need it, and cost is an issue?
Okay. Of course, like for IgA nephropathy, actually, I'm waiting for a trial done in China that they're gonna use a lower dose of steroids instead of getting 1 mkd for 6 months. They have done. They called it the low-dose testing trial of 0.5, and hopefully that the cosmetic issues would not be a problem. Now, if other problems arise also, then we give the second-line therapy, like for IgA nephropathy, then maybe MMF is an option. And for lupus, of course, maybe you could do without the steroids and give the CNIs or mycophenolate.
Okay, another question for Dr. Andres. So in case of an FSGS patient only has partial remission to steroid, what will be your treatment of choice that you can use for 6 months as well?
As we have said, we can partial remission. We can continue our treatment with steroids up to 6 months, and if the patient is still has partial remission, maybe consider adding or shifting to CNI.
So CNI. Last question maybe. So a question on anticoagulation for membranous nephropathy is being asked, Dr. Andres. Warfarin, your thoughts?
Okay, that is a very, wait lang. I will share to you a slide because I did the GN tools, but I did not show it anymore. Here it is. Can you see it?
Not yet.
Wait lang. Sorry. Well, we know that. Wait lang. I just want to show you the GN tools app because it. Here, just a second. There it is. Can you see it now?
Yes, you're good. Just shift it to presenter's view.
How?
Sa baba.
Sa baba. Sorry. Okay. Okay. So this is the recommendation for anticoagulation. So patients with massive proteinuria or heavy proteinuria, usually seen in membranous nephropathy, it is good to use this GN tools, and these are for prophylactic anticoagulation in patients with membranous. So you just input the results here, and I did input the results for our patient with membranous, and it showed that she has zero or low risk of bleeding, and she will low risk of bleeding, and she will benefit from 90+ benefit chance of benefit from anticoagulation. However, when you decide to do anticoagulation, you have certain criteria to follow. First criteria is if the serum albumin is less than 2, if the patient has a genetic predisposition to thromboembolism or thromboembolic event, if the patient undergoes abdominal surgery or orthopedic surgery, or if the patient is immobile. So, so these are the criteria that we check to decide to give anticoagulation in our nephrotic patients. So in this patient, we did not do we did not give her anticoagulation because even if she has low risk of bleeding and 90+% benefit for anticoagulation, because she only she only had one criterion present, and that was the less than 2 grams. So we said no na lang. But we can give either warfarin or low molecular weight heparin. There have not been any studies yet that have proven beneficial as anticoagulants among patients with nephrotic syndrome for your factor 10A inhibitors, or your the other one, factor 10A, and the thrombin
Antithrombin.
yes, antithrombin inhibitors. So that's a very good question. Yes, anticoagulation should also be considered in these patients with massive proteinuria.
Very last question. The question, it also asks the target INR. Should you consider giving warfarin? What should be the target INR?
Well, the recommended target INR is 2 to 3 times the normal, same as the usual INR that we target.
Okay, so with that, I think we have to conclude this webinar.
Yes.
It's 8 o'clock. It has been a very exciting and productive evening for us. We would like to thank everyone who made this possible. All the participants who joined us tonight, thank you very much, Dr. Russell Villanueva and Dr. Andres. So in behalf of the PSN, thank you very much for joining us. And announcement for next week, another exciting topic will be lectured on by Dr. Agnes Mejia. The title is The Kidneys in the Failing Heart. So that will be August 5, again at 6 p.m. So please join us next week for another web series. So thank you again for attending, and good night.